I would like to introduce our keynote speaker for today. Dr. Arash Kia is an assistant professor in the Department of Anesthesiology, Pre-Operative and Pain Medicine at the Ishan School of Medicine at Mt Sinai, where he also directs the clinical data science team. His role extends to leading Mt Sinai's health system's efforts in operationalizing machine learning solutions that target improvements in clinical effectiveness and patient safety. His team has developed multiple ML applications that help in assessing risk factors, such as deterioration, ICU transfers, and delirium to enhance patient care across a variety of different clinical settings. With more than 10 years of experience in data science focused on healthcare innovation, Dr. Kia has been instrumental in integrating over 20 different machine learning applications into production over 7 different academic hospitals. He established and has led the clinical data science team since its inception 7 years ago and has been crucial in designing data processing architectures that have been foundational for implementing AI technologies. And I think it's going to be important for us today to also look at his presentation through the lens of whether you're a PT, OT, nurse, physician, health informaticist, that AI is going to impact all of us regardless of what care delivery position you are in. So with that, I'd like to introduce our keynote speaker, Dr. Arash Kia.
Hi everyone, and thank you for having this opportunity to share whatever we have done so far in Mt Sinai Health System, to share that. So the main actually agenda items that I want to cover in my presentation is, first I start with general overview of AI. So what would be the definition of the AI that me and my team actually, and overall in Mt Sinai Health System, we are actually thinking about, and we are building all of our products around that. Because AI is pretty vague and it has very actually wide spectrum. And then I'll actually very briefly discuss what products we have done, we have built and operationalized, and how we did that. So our platform overview is giving you some very high level kind of insight that how we put all this actually kind of components that we need for deploying and implementing kind of softwares, applications, and AI systems. And at the end, I give you 2 case studies actually showcasing 2 of our actually projects. I thought that maybe it would be interesting for you guys. And the most important piece for me is actually the QA and getting feedback from you, and also having a discussion. Hopefully I can actually cut all of my presentations in and presenting in around actually 25 minutes, hopefully. So what is the AI? So AI actually for ourselves is system. AI is not a model, AI is not a software, and AI is not a workflow. AI is a system that should actually autonomously process large amount of data, the data that actually is not possible for human to retrieve and do the analysis and extract meaningful insights. So in our domain is actually clinical insight, and there should be some level of adaptation. For example, so when we actually make a decision, in all situations we don't have all the piece of information, data that we need, but we somehow kind of adjust ourselves and make the best actually decision about that. So this system also should do that actually type of adoption. And then another thing is improving the performance. So we start with actually decent performance that we decide that this is decent based on all the benchmarking and everything that we do when we actually come up with the AI tool. And then actually, during actually different type of versioning, it should show the performance improvement. So another actually topic that we don't have kind of time to kind of delve in is the responsible AI, because we build these kind of tools, it somehow also make a bias, bias even for the people that are using that, a bias about in our actually the care service that we provide. We should be actually very sensitive about that piece, about actually the security, the privacy, and kind of health equity as well. We have a kind of committee that what we do is we try to actually use case by use case, come up with some kind of indicators and also metrics and acceptance actually level for each metrics, and try to actually make a decision, this is actually good or this is not good actually, and then make a decision about the operationalization. So in Mt Sinai Health System, when we start actually to build our first AI tool, this is how we actually conceptualize our main subject. So we decided to do actually all of our optimization around decision support cycle, which is happening at the bedside all the time. So it has three main components. It has data, it has knowledge, and it has learning. So at the bedside, everything starts with kind of documentation. Clinicians, they do the evaluation, the request for, or actually put the order for different lab actually exams, and so there are tons of different actually nursing evaluation gets documented through the different flow sheets, and there are actually a huge amount of data based on the documentation. So what actually a clinician does is actually retrieve the data based on the different actual span. So it can be from the admission time. It can be actually if the clinician knows the patients, it might be actually from two last outpatient kind of encounter the patient had, or for the readmitted cases from 2-3 previous actually inpatient encounter, and they try to actually do the data aggregation. So in different actually kind of views, in the lab views, what was the trend of BUN creatinine, and they try to actually come up with some kind of, based on that aggregation, come up with some kind of differential diagnosis, come up with a treatment plan, and everything is in the iterative kind of mode. And also sometimes they actually they request a consult, another actually discipline. They come and say that, okay, the patient may be at a high risk of acute renal failure, and so they actually somehow modify the goal of treatments and the treatment plan. And all together, it creates the quality of care. Without that, okay, this is a good start for us because it's about the computation, it's about data, and we can actually automate everything and try to come up with kind of machine learning model in between to optimize some of the decisions. I won't actually go inside of the actually our product development life cycle. This is also another kind of topic which takes a long time. But what we do is we get the optimization opportunities as a problem statement, usually from actually the leadership. So currently, everything is actually top-down, but the best case scenario is we have a kind of system that we get all the optimization opportunity from the frontline worker and try to build actually very solid problem statement. And then based on that, what we actually do, we come up with some kind of solution architecture and some kind of prototyping the future workflow. We built a working group. We present actually that to the working group of the potential users, the product owner, and data scientists, even actually DevOps engineers are part of that working group. And then they try to actually validate that and say, okay, this is actually nice kind of prototype. This is what we are looking for. And then we do our kind of product development, design 1,000 different actually experimentation, do the optimization, do the testing, everything is right. Then we deploy it. What is a deployment? We plug in the different actually platforms and get the stream of data, see that how in the prospective setting, not the retrospective setting, is working, is it same or not, and what is the workload that is generating, and also the responsible AI comes to the picture exact at this moment, because then we can actually say that, okay, is this oncology prognosis application hitting more some kind of specific kind of ethnicity group or specific race or not, and what is the impact? The precision is changing racially or not, and any kind of disparities creating or not. And then everything is good. We pass the silent pilot, we call this silent pilot, and then we go to active pilot in a couple of units and then scale up. And it doesn't stop there, because now we have a system. When we are talking about the AI as a system, now here is the system. So we have a user, we have an engine, user and engine, they're working with each other. Users are learning from the pattern that the AI tool is identifying, and most of the time in the gray area, so users actually learn from the tool, and also tool learns from them, because they give the feedback. We build our suppression logic wherever actually it's a specific logic that is workflow related. They're gonna stop getting notification or any alert. Then they actually add to that, and this is actually version 1, 2, 3, and so on. So far we built 16 different products operationalized in 6 hospitals, main hospitals, Epic Shop hospitals in actually in Mt Sinai Health System. We are generating more than 15 million predictions per year. The products are pretty actually wide. We started from something very actually simple and easy for risk stratification. It's not an easy actually domain. Identifying risk of severe and moderate and severe malnutrition inside of the acute care setting. It's actually pretty successful. We significantly changed the success rate of the registered dietitians to identify the patients. It's a prioritization tool. Pure based on the lab, nursing evaluations, structured and semi-structured and EKG data. Till something which is pure actually NLP and unstructured, like we build a language model to ingest all the ED notes and identify the part of the notes which is actually stigmatizing, is using stigmatizing language, discrediting patients or other categories of the stigmatization that have been actually identified with our FAIR working group that we have inside of the medical school. Currently, it's very passive. This language model work we use only for education, identifying where is which point of care, which type of clinicians they are the goal for improvement, and then we through some kind of workshop and make them more sensitive about the language that they're using. But in future, we have a plan to actually integrate with Epic, and then that would be more active. So when they are using, something pops up, gives them some kind of options, and they can actually pick. We have some kind of event-winning kind of application. Is a type of application that identifies what is the best time to extubate patients when they're actually on vent. This is kind of fusion of the imaging. We have our application is ingesting the chest X-ray and generate the prediction score, and also that prediction score gets embedded in another application, which is using the lab structured, unstructured data together. Okay, so our CDS platform. So the platform is actually including some of the kind of applications, pipelines, some components like the interfacing components with doing the data exchange. Our philosophy in developing this CDS clinical data science platform should be automated, should be the reproducibility should be very high, should be modular, and also easily scalable and platform agnostic in a way that some hospitals they have different platforms. It should be easily integrated. So here is the very general overview of our platform. As you can see, so there are some data producers. These are different platforms, ADT platforms, the admission, discharge, transfer platform. Epic, we have our EMR as Epic as our EMR. We have for lab, we have different kind of platform. We have LabCorp, SunQuest. Each hospital they have their own, based on their vendor management strategy, they pick their own company of interest. And we have also the PACS, currently is GE PACS, which is changing. And we are in the middle of integrating with EMS. So in that case, it extends the data that we are receiving from the first patient encounter outside of the hospital. It's very important for us for our stroke program and for our triage application that we built for that. And also the wearable. We have Massimo currently, so that wearable device mainly are the inpatient wearable devices that we are using mainly for vitals, not more than that. We get all of this data, and everything goes to the kind of our very open source light interface in the format of some specific file, which is XML file, HL7 kind of language. It has its own standard. And then we dump everything into our data lake, and we developed a bunch of streaming data services in the streaming mode. It gets all the data and creates single view at the lab view, at the visit level, at the actually patient level, which creates something easy for kind of modeling and computation. And we have two types of databases, mainly NoSQL. It's actually not relational databases. And then we have our ML applications that get feed of this all the streams and generate predictions, notifications, alerts, send it to either to the Epic as a passive, and clinicians, they can create their own patient list and rank the patients based on the high risk, low risk, or we are sending to the Voicera, which is a smart pager. We are sending to the smartphone app. We used to use Curator, which was open source. Now we're using Haiku, which is Epic smartphone application, and also we send to the Command Center. We have an imaging platform. I won't go through all the pieces, but it has two kind of branch batch pipeline, which we actually get the images using a transfer learning approach to retrain some of the pre-trained model that we get, play with different deep learning architectures, see that which one can give us the best result, optimize that. And also another thing that we have which is common between the streaming pipeline and batch pipeline, is the image processing. All the steps of the processing that we need to do over X-rays, CT, MRI, in order to make them usable for the deep learning pipelines, we make them in one centralized module, and the good thing is that in that module is we can manipulate based on our needs. And the other interesting point is, so usually deep learning applications are very is like black box. So they just give you the final answer that you're looking for. But in the imaging, we try to get the feature map of the deep learning and try to visualize that. And as you can see here, we are using the GradCam kind of technique that try to see that what was the pixels that had maximum kind of a contribution in the prediction, and showing us a heat map. I won't go through the image processing. This is actually some of the examples of the chest X-ray that we are using in the event winning application. We are doing the segmentation. For segmentation, we are using another deep learning techniques to do that automatically. And the way that we came up with this module of the segmentation is every day you see that new deep learning architecture is coming into the market. We have a pipeline that can in an automated way measure the performance, see that how we can easily use that, and if we use that is improving our performance or not, and then replace it with that. So that's also interesting. The NLP pipeline is also one of the pipelines in our platform. We get all types of unstructured data, which gets produced inside of the EMR. We get that, and we have some kind of steps, traditional steps of the NLP, and then using two pre-trained models. The embedding is at the word level or at the sentence level. It generates big vectors, which is representing the location of the word in that text. And by using actually that location of the word, and sometimes actually you can have different representation for the sentence. And by training of that, the model can actually identify, which word, for example, is diagnosis, which word is signs, symptoms, yeah. So these are actually called a name entity recognition pre-trained model. Usually same as actually the imaging kind of deep learning models. What we do, we use transfer learning. So it was trained on the large actually body of the text using, I don't know, PubMed, or using actually non-clinical kind of documents. But what we do, we actually bring back our data and our notes, reports, and then actually retrain them, customize the models based on our actually what our kind of acceptance criteria, and improve the performance. And then we actually use that for training of different classifier, note classifier, and we operationalize them. So recently, Gen AI, I think everybody knows about the large language models, and most likely all of you are using ChatGPT. So what we use also, we get all of this actually GPT, different type of GPT. So because of the some kind of strategy, we only use OpenAI, but hopefully we see a day that we can be free in using different kind of large language model that every day is coming to the market. Now, what our pipeline is doing is low code, so we just actually create the JSON from the TXT file, that big actually document that we have, and then try to use whatever embedded in that large language model. They have a tokenizer, they have actually that kind of embedding model inside of them, and we call the API, and in a zero shot we get whatever we put in the prompt, but in an automated way. Sometimes the zero shot actually works. It means that we can actually use that large language model as is. Sometimes few shots means actually giving them 5, 6 actually example in the prompt, and then it works. Some of them, none of them is. Some of the times, none of them works. We should do the refining. Usually, these days, actually, refining is very expensive, and updating 70 billion actually parameters with, 10,000 notes, it's almost impossible. And so that's our actually situation in Gen AI. I won't go through our actually a diagram how we deploy that at the engineering actually level inside of our cloud. That's another actually topic that I skip. But the first actually use case that I want you walk through that is actually is a Delirium actually screening tool that we developed and operationalized. I guess everybody knows about Delirium, but in a very short kind of sentence, Delirium is a confusional state. Patients temporarily get confused, and it comes and goes. And if actually the frequency is high, is kind of gets important clinically. So identifying delirium is very challenging. First of all, it's very actually subjective assessment. Subjective means inter-rater reliability is very low. Finding actually 5 physicians, 3 physicians saying at the same time that the patient has a delirium or is delirious or not, it's very tough. If you want to make the standardization, you need to actually do the extensive training. It's very resource intensive. It has a patient factor, and also because the symptoms is fluctuating, patient actually, the clinicians, they can come and say, no, this patient is not delirious. This other time, I don't know, 10 minutes, 15 minutes later, some other clinicians, they come for the consults. No, this is delirious, yeah. And specifically in the floor, not in the ICU, so the prevalence also is not very high, is low. Another challenge, the class imbalance. If you want to actually build something, low prevalence is the chance of learning from the positive cases would be very low because most of the cases are negative. And because of all of these challenges, actually, it's underreporting usually. So what was our optimization strategy here? We said that, okay, if we can build a tool to do the automated clinical profiling at the beginning we thought that it can be actually real time, but then when we wanted to actually operationalize that, we found that actually it's very tough for the users to see the prediction scores gets updated in a real time, every 5 minutes, every 10 minutes, 15 minutes. So it's going to be very actually confusing. Then we started to do it one time per day, 6 a.m. And then send all the prediction scores into the Epic. And they can, so by using that, they can actually, the confusion assessment assessors, they can actually prioritize the patients. High risk, they can actually pick them. And the other thing is actually, we have an opportunity of standardization here. We actually linked the engine with the users. We have a kind of closed loop. And we hope that actually we have an optimized identification. And we came up with a workflow that every day that I told you, and some kind of suppression logic for which patients actually they should suppress, for which patient they shouldn't suppress, and if the CAM assessors actually they visit the patients, evaluate the patients, say that actually no, the patient doesn't have, so it gets suppressed for 5 days. If they say yes, so that's actually financial kind of decision, yeah. It's yes, then we found actually some cases that can get upcoded, and in terms of the revenue for the hospital, mission is completed, yeah. But it shouldn't be like that. So we should be more actually sensitive about the care rather than actually financial, but that's the situation. So we had actually a couple of versions. In the last version that we had, it showed actually it's a combination of nodes, so unstructured data, structured data like lab, waveform data like actually EKG, and semi-structured like nursing kind of flow sheets. Gave us really good ROC score. As you can see here, sensitivity specificity is actually quite amazing. It's 83% sensitivity, 90% kind of specificity. And then in terms of the efficiency, as you can see here, when we started, so in 2019, it was actually, there was no ML tool. And the size of the team in one of the hospitals was 5. So the hospital is 1,400 actually bed. So the detection rate was less than 5%. So I didn't put actually here version 2.0, but in version 1.1, so as you can see here, significantly it's actually improved, yeah. So something around actually 12%. From 5%, our detection rate jumped 12%. And the team size went down, yeah. So, you know, that after the kind of COVID, everything is going down, yeah. That happened to our actually CAM assessment team as well. And then the other thing we checked was admission detection lag, yeah. So without using ML in our screening workflow, as you can see, it was something around, I don't know, 14 days was the lag between the admission detecting first episode of delirium. Now it got shorter, yeah. So something around 10, between 9 and 10 actually days is the time that we have. I don't know, I have another, have time or? Yes. Okay. So another actually use case that I want to present is actually the aggression predictive tool. Developing aggression in the psych units is challenging, yeah. So because the first thing, based on the common sense, is they need to have one-on-one observation. It's expensive. The other thing is, it's easy to predict the aggression episode, developing aggression episode in psych units. But in non-psych, if you want to scale up, it's very tough because you need to have trained RNs or use CL, actually psychiatrists, which is very expensive. What we have done is we started our automation by actually saying that, okay, what in psych units they're doing is they're using a questionnaire, which is that approach in psychiatry is actually very common. Yeah, they have a checklist of here is actually Broset violence checklist. As is like rule engine. It has 6 items, 0, 1, 0, 0, 1, and they have actually cutoff point. Everything is deterministic. So okay. So first start using NLP to see that can we automate this or not. It means that looking back in the last 24 hours kind of note each day and look for this confusion, boisterous, irritability, and then come up with a score. And whatever threshold that they're using, we can actually use that and send for each shift, we can actually send the expected Broset there. That would be actually our first step. If this works, then what we can do is, this is deterministic. It's 101, 0, 1, everything is binary, and it's rule engine. We can build a machine learning which is probabilistic, because the situation is probabilistic situation, it's not a deterministic. And what we have done is skip all of this. We came up with a workflow, and the first actually kind of the first kind of goal that we had to generate the expected Broset for each shift was successful. I didn't actually include the result here, but this is workflow. But then that success led us to another actually experiment. The second one is that now, instead of using 6 items, how about we incorporate all the comorbidities of the patients, extracting from the notes, all the signs and symptoms, all the medications that the patients are actually getting, and then see that can we build a machine learning based score saying that this is actually chance of developing episode of aggression within next 12 hours or not. And we did that. And as you can see here, we said, okay, now let's see that when we run this in our psych units and check this with the safety net data, which we have the kind of documented aggression episode for the patients, for the psych patients. Let's compare the performance of the actual process that nursing staff, they're actually doing the evaluation, documenting in EPIC, versus the expected process one, which doing that process only automation with the actually the machine learning model. As you can see here, it was interesting. I don't know, this is 1 year data, but maybe if we actually do for more than 1 year, something comes up here. But basically, none of the nursing staff-based kind of evaluation process identified even one case of documented aggression episode. Whereas you can see the automated process one showed 40% kind of performance and sensitivity, and more than 40% was actually the machine learning one. And when we actually open the most important features and take a look, so as you can see here, agitation is irritabilities, and also some medications, some kind of antipsychotic medications, some actually pain, and so it's also you see the boisterous here, loud yell, and it's a combination of different things. It's not actually only 6 items. I'm done. Thank you.